And we'll talk about the younger athlete rather than the young athlete because we're all young at heart, right? So this is applicable to many of us. A lot of the injuries we heard about earlier certainly can happen in the younger athlete, the high school athlete and above, but the very young athlete, the skeletally immature athlete, has some forgiveness in that their tissues are highly more elastic. Now, maybe not as strong, but we don't see rotator cuff tears, for example, in athletes younger than 15 or 14. Doesn't mean we don't see the same overuse injuries that we've heard a lot about tonight, and those are really the biggest bugaboos. We also see some shoulder instability, which is similar, and you heard some discussion about the younger athlete being one who might be a greater risk for redislocation. The data, I don't think, is really in the under 15, under 14, the truly skeletally immature athlete in terms of instability. But as you probably have heard, the overuse injury is microtraumatic damage to bone, muscle, or tendon has been subjected to repetitive stress without sufficient time to heal or undergo the natural reparative process. We can all heal things up, younger better than older. But young kids nowadays are getting more and more overuse injuries because of the inability to have the time to heal. Folks I trained with, Lyle McKaylee started the first pediatric sports medicine clinic in the country in 1974. When he was in training, they saw broken bones because kids fell off jungle gyms. And now there are dedicated sports medicine practices for kids with these overuse injuries that he never saw in his training day because of some of the issues we'll talk about as we go along. So you've seen some of the classifications. A classification for an overuse injury might be pain in the affected area after activity. So this is what you might watch for in your kids if they're describing an increasing degree of overuse injury. Pain that then persists during activity without restricting performance. So typically we see it after activity. Sometimes it starts to affect their performance. Then there's pain that activity that does restrict the performance. You see it impairing their abilities. And then chronic unremitting pain, even at rest, is certainly worrisome. So for the skeletally immature athlete, there are a couple of injuries that are very unique as opposed to a lot of the overuse tendinopathies we've heard about earlier. And those are injuries that affect the growth plates. The growing cartilage within bone is what's very unique about prepubertal kids that the rest of us don't have anymore. So the physis or the epiphysis, the apophysis, all the growing cartilaginous plates around the joints. And kids still do, by and large, get a lot of multidirectional instability and some rotator cuff tendinopathy without tears. But the specific things we'll talk about just briefly are little leaguer's elbow and shoulder. And then a couple other injuries I threw in there that aren't shoulder injuries that you might see in your kids are similarly these physeal problems, the Osgood-Schlatter's in the knee, the osteochondritis dissecans we were about, and the Sievers. So we've seen the anatomy, humeral head, clavicle. We've seen this a few times. For a little leaguer, or someone who's a little overhead activity as a swimmer or tennis player, you can actually have a stress injury of the proximal humeral physis or the growth plate at the top of that upper arm bone. And what we see is shoulder pain, easy fatigability, and then if they're a thrower, they can have decreased velocity, accuracy, or performance. This is what it looks like. So this is we've seen this humeral bone several times already tonight, but the kids have a growth plate right there, crack, if you would. This is normally a crack. And when we see a widened growth plate, as it's diagrammed here in the cartoon, the x-ray is not exactly hugely diagnostic, but sometimes we're actually left trying to compare the kids with their own side. We have to get bilateral films, even though they're injured on one side, to see what the displacement of the growth plate is. So this is the concerning growth plate injury that Chad mentioned, that we worry may have long-term effects and that they may have disrupted or altered growth of the growth plate, therefore allowing the bone to grow in an abnormal direction, not as straight as it would. Fortunately, that's pretty darn rare. I mean, I think we worry about it a lot more than we actually see it, but we do worry about it. Little league elbow, similar around the elbow. I'll show a picture. There's a bunch of growth plates around the elbow, but you can see here, you might appreciate a widening here of the apophysis here, the medial epicondyle, and that's little leaguer's elbow, which we see maybe a little bit more commonly than little leaguer's shoulder. In an older athlete, you tear the ligament that we don't see here in the x-ray. That's the basis of the Tommy John surgery. And the younger athlete, you have that injury. Nice thing is, for younger athletes, bone heals with bone. And bone has really great healing capability. Bone heals with bone, heals as good as new. Ligament doesn't so much. That's why the surgeons end up doing the Tommy John surgery. They sometimes have to repair capsules and do Bankart repairs, et cetera. But if you give bone a chance, if it doesn't get pulled too far off, it'll heal up. So the treatment, pretty boring, rest. At least 6 weeks. Well, it's boring for a young athlete who wants to be busy. And my challenge actually as a pediatrician is to answer somebody's question just a few minutes ago. Every kid should be an athlete. Every kid's an athlete. Every kid should be active and should be an athlete. It's not just those who are necessarily doing any organized sports. We have an obesity epidemic, which is the bigger problem we have in this country with kids. So, but some really want to be active. So at least 6 weeks, sometimes up to 6 months of rest for these bony injuries. No throwing for at least 3 months. Have that conversation in March with a young athlete who's looking forward to baseball season. We do all the time, my colleagues and I. And then a good structured rehab like Chad described to return safely to throwing. As young as 9 or 10, I've seen Little League Elbow. And so I've had kids go through that type of a program with a therapist. What do we do in pediatrics? We live for prevention. We immunize kids. We try and get rid of disease and illness. So we heard some of the detailed points. I'm going to really hammer these home as we finish up, sort of a little bit of dessert. This will be lighter than some of the stuff maybe we've heard earlier tonight, not as meaty, not as much anatomy. But I was pleased to serve on a panel a couple of years ago put together by the National Athletic Trainers Association that looked at the literature to try and determine what do we have evidence for that's prevention. So we heard about injury surveillance, identification of risk factors for injury. Chad pointed out some of them around the throwing shoulder. We do pre-participation physical examinations that kids have to come into at least before they get into high school, maybe not at younger ages. Proper supervision in education, coaching and medical. So glad that so many are here tonight. How many are coaches? I mean, getting yourself educated. In Ohio, where I came from, coaches had mandatory education, had to show a certificate. Getting yourself educated about these things is among the best things you can do. Sport alterations, we'll talk a little bit about training and conditioning programs, and delaying specialization as long as you can. I'm going to talk about 4 of these in the next little bit. So the biggest risk factor for young athletes, although there are a lot of the other anatomic and physical therapy deficits that Chad talked about in older athletes, but for younger throwers is a growing but not a completely full body of literature to suggest any of those factors. The big things are arm pain and fatigue and decreasing pitching counts. These other things, the midfoot hyperpronation, some of the things Dr. Silby talked about can be more interesting, but by and large it's volume in young throwers. And detecting fatigue early, kids aren't lying sometimes. They don't know they're fatigued. Their accuracy's off. They're not throwing strikes anymore. They're walking batters. They're wild. Everett Logan, I'm going to give a plug to in a little bit, is in the audience. He's a really good pitching coach locally. Their velocity being off. People talk about they're not wanting to use, we'll get to this, not wanting to use pitch counts, radar guns to get their velocity measurement because kids might overthrow. Maybe the opposite, the kids don't appreciate that their velocity is decreasing. That's the first sign of fatigue. So those are keys. We're being educated tonight. I'm going to put in a plug. Any certified athletic trainers in the audience? These are not too many. These are trained, skilled, allied health professionals who know how to look out for this stuff, know how to help prevent, recognize, assess, treat, and rehabilitate athletic injuries. Any high school that has an athletic program should have one of these people on their staff. This comes from Fleissig and Olson and Andrew's group. We've heard a lot about them tonight. It's a list that we had published in this journal. They updated this just in 2012. So the position statement for youth baseball pitchers from the American Sports Medicine Institute, which is where all of the major league players go down to Birmingham. Again, watching and responding for signs of fatigue, decreased velocity, decreased accuracy, upright trunk during pitching, dropped elbow, increased time between pitches. If a youth pitcher complains of fatigue or looks fatigued, let him rest from pitching and other throwing. No overt throwing or of any kind for at least 2 to 3 months per year. 4 months is preferred. No competitive baseball pitching for at least 4 months per year. Do not pitch more than 100 innings in a game in any calendar year. 100 innings in games in any calendar year. And follow limits for pitch counts and days rest. Different organizations have different specific pitch counts, and this group publishes regularly on pitch counts, but you have to follow those. Avoid pitching on multiple teams with overlapping seasons. Learn good throwing mechanics as soon as possible. The first step should be learn and order basic throwing even before fastball pitching, good mechanics, and then change up pitching. You heard about the controversy, which isn't as controversial about the curveball, but the problem is kids are trying to throw curveballs, don't have the other pitching mechanics down right, and they probably then are throwing themselves into worse mechanics by trying to throw the curveball. If the curveball is thrown properly, if the biomechanical studies would suggest that it's no worse on the shoulder or the arm than any other type of pitch. But that's an enormous itch if, and many can't throw with the right mechanics. I touched upon avoiding using radar guns. I rely a lot on Everett because he pays attention to this material, but he disagrees with Andrews and Fleissig on this because his vast experience coaching young pitchers is that they do not try to overthrow the gun. They, in fact, you need to have that information to know because the fatigue sets in well before even the trained eye can detect that the fatigue is there. A pitcher should not be also a catcher for his team. So we used to learn about in fellowship that actually the number of throws, the number of skilled throws a day has to be counted, not just the number of pitches. And all the throws back to the pitcher, or especially the throws down to second base, those add up, those count. And you should have a total number of throws. So a lot of these best athletes on the team are the pitchers, and they also happen to be the catchers because those are crucial positions. And they play shortstop, another set of skilled hard throws that you have to pay attention to. Pain in the elbow or shoulder, discontinue pitching until evaluated by a sports medicine physician. A little bit self-serving from Andrews. But here's one set of pitch counts. They've been revised. You can find them at ASMI, American Sports Medicine Institute.org, in their position statement. Little League Baseball has pitch counts. They're not to protect you. It doesn't mean you can go up to that pitch count safely. If someone has fatigue or decreased accuracy or pain below those pitch counts, unfortunately, sometimes we might be tempted to say, oh, they've not reached their limit yet. They can keep going. Their limit is whatever their limit is. And frequently, it'll be less than the number that's published for the population as a whole. So individual treatment is the key. This is my big bugaboo, delayed specialization. So we see more and more kids doing one sport for year-round rather than increasing their athleticism like Chad talks about. And the American Academy of Pediatrics, which I belong to, published an updated statement about overuse injuries, overtraining, and burnout in child adolescent athletes. I think this is from 2008. And we talked about trying to make sure that kids have at least 1 to 2 days a week totally off from training and athletic activity. 1 or 2 days a week. Maybe just one would be nice. Increasing volume when they are in stages of returning to participation or preseason, or especially coming back from injury, trying not to increase the volume, the total volume of activity by more than 10% a week. So swimmers, it's a little bit easier because they have their number of yards or number of meters that they swim, and they can really tell you to the meter how much they swim. Pitchers, it's a little bit okay because they might be pitch counting. Runners, they have mileage. But once you start getting into team sports, you can talk about hours on the ice for hockey and things like that, but this is really about repetitions. We've heard about the 2 to 3 month break from every sport, trying to be only one competitive team per season, trying to be on only one competitive team per season, and special precautions for the younger athletes participating in those compressed multi-game tournaments. Soccer is a big offender here. So we had one of our fellows in Akron do a study of some high school athletes, self-reported, and we found it very, very interesting that looking at the rates of overuse injury as they reported it, and if they were doing 4 seasons of activity, and we thought it was going to be number of seasons of the same sport versus different sports, but it really just argued that kids who are doing any 4 seasons versus those who took 1 season a year off had about a 42% increased chance of overuse injury than kids who did 3 seasons and took a season off. They could train in the off season, but they weren't involved in a sport. And then when we looked at the same versus different, it wasn't as significant when we adjusted for each other. Another study came out, was multi-center from a bunch of pediatric sports medicine practices not involving us, that looked at parental reports of overuse injury. One of the big ones that was significant was too much playing time without enough rest, and then the number of games within 48 hours before the injury. But the big one that came through was sleeping 6 or few hours the night before the injury was associated with all fatigue-related injuries in youth sports, getting enough rest. A very recent study just presented at the Academy of Pediatrics meeting also showed in an elite Los Angeles area prep school where they tracked injury rates very tightly and had an injury reporting surveillance system with athletic trainers. This is self-report. That the same thing. They thought it was going to be 4 seasons versus 3 or multiple sports like we always thought. They found the only thing that held true in that group was, again, sleep. Those who had less sleep had a higher rate of injury than the others. So we worry about burnout. We worry about overtraining syndrome, a series of psychological, physiologic, and hormonal changes that result in decreased sports performance in addition to injury. And recognizing it, well, adults can get it too. It's a little bit better specified in adults in that they can have chronic muscle or joint pain. There can be actual personality changes associated with burnout. They have an elevated resting heart rate sometimes, and they perform poorly in sports. Kids are a little bit harder to read. Fatigue has been associated with it, lack of enthusiasm about practice or competition, difficulty with successfully completing usual routines. So keeping them avoiding burnout and keeping them avoiding injury includes trying to keep the workouts interesting with age-appropriate games and training, keep practices fun, take time off from organized or structured sports participation 1 or 2 days per week to allow the body to rest and do other activities, permit longer scheduled breaks from training and competition every 2 to 3 months while focusing on other activities, and doing some cross-training to prevent loss of skill. And focus on wellness and teaching athletes to be in tune with their bodies for clues to slow down or alter their training methods. That's harder with the really younger kid who doesn't really understand those clues. But a very simple take-home message for kids is, really, if it's not fun, if they're not having fun, then why are we making them do that? So